Thank you all so much for joining today and hearing about some work that has taken up a lot of my time for the last couple of years, but I have to say that I've never been so excited to join 7 a.m. meetings on a regular Wednesday basis as for the project that I'm going to be talking about here. So first of all, my disclosures, and the one that I want to just mention the most is that a lot of what I'm going to talk about comes from efforts that really were born out of the Michael J. Fox Foundation sponsored Parkinson's Progression Marker Initiative, where I'm on the executive steering committee, but really evolved past that. And this is a collaborative team. A lot of the data I'm going to show you is not mine all personally. It comes from this collaborative effort, which is a group of academics, industry, regulators. We have patient advocacy groups as well as patients themselves on this group and as authors on some of these papers, in addition to work that has been done outside of this group that supports what we're talking about. So a very collaborative and interactive group of individuals. So for just a moment, imagine a 50-year-old woman walks in to her primary care doctor for a well-person visit. They start off talking about cardiovascular risk, family history, personal risk. They do a lipid panel, they check blood pressure, and they put together a personalized plan for the prevention of cardiovascular and cerebrovascular disease in the future. They then talk about cancer screening. Again, genetic risk, exposures. They put together what screening evaluations she needs in order to understand exactly what her cancer risk is and put together a personalized plan for the prevention of cancer in the future. They then talk about neurodegenerative diseases, again, environmental risks and genetic risks. And they just put together a screening panel, maybe a blood panel, maybe something else, of different proteins, amyloid, tau, synuclein, TDP-43, other neurodegenerative associated proteins. And they put together a personalized plan for the prevention of neurodegenerative diseases. This is the future that we believe is now possible. And 15 years ago, I would have said this is as much science fiction in my lifetime as me being able to get on a shuttle and go to Mars. But at this point, I think that we actually are on the precipice of actually thinking through how this could become possible, how neurodegenerative diseases of aging could potentially move into this space. So what am I talking about here when I use the word prevention? I just want to clarify some things. So when we talk about therapeutic development in the context of prevention, there's a couple of different aspects of prevention. First of all, there's primary prevention. That's actually what we're talking about with a lot of the cardiovascular work that is being done. Smoking prevention, healthy diet. This is really preventing the pathogenesis of occurring in the first place. And there's actually some great work being done here in terms of Parkinson's disease. As we all know, there's certain pesticide risks and other exposures that dramatically increase your risk of Parkinson's disease. And if anyone wants to read more about this, this is a great book, Ending Parkinson's Disease, that colleagues of mine wrote. That was very provocative in saying, kind of this 100-year plan of if we can get rid of these environmental toxins, we could really dramatically reduce the overall number of individuals with Parkinson's disease. This is the long game. This is important work, but this isn't necessarily what I'm talking about today. These are people who are at risk, but have no evidence of biological disease whatsoever. Most of the clinical trials are working in the tertiary prevention space. So this is individuals who have disease, who have a diagnosis with clinical symptoms, and you're really just trying to prevent further consequences of that disease and further functional impairment. We have drugs that can treat things symptomatically, and there are therapies that are currently in clinical trials, not yet successful in Parkinson's disease, but currently being tried to try to slow the progression once people have a diagnosis. These are people who are biomarker positive, pathology positive, and they have the clinical symptoms of disease. What I'm talking about is secondary prevention. These are individuals who have evidence of biomarkers, they have evidence of disease, but they have absolutely no symptoms. And this is the space where we want to potentially identify people who have biology, but don't have the clinical manifestations of the symptoms yet. The challenge with this space is exactly what I said. They are symptom-free. Symptom-free means syndrome-free. And all of our neurodegenerative diseases at this point in time are defined by their clinical syndromes. So how do we move into a secondary prevention space when everything we do is syndrome-based? And this is the major paradigm shift that has to happen if we're ever going to even conceptualize the idea of identifying people in the secondary prevention space. So why do we think secondary prevention is possible or even probable in neurodegenerative diseases? The reason is that the clinical syndrome actually develops decades after the biology starts. We know this pretty well at this point in time. Clearly for Parkinson's disease, for dementia with Lewy bodies, for Alzheimer's disease, most likely for frontotemporal dementia, most likely for ALS and other symptoms. The amount of time varies for these different neurodegenerative diseases, but we do know that the pathology starts years to decades before. So there's actually a pretty darn big window of opportunity to catch people when they have biology but no symptoms, where we might be able to do something meaningful to stop the onset of symptoms. And so that's why neurodegenerative diseases of aging are actually quite primed for a secondary prevention model. But this is where we all live, right? And I'm going to use Parkinson's disease as the example, but you could put in here dementia with Lewy bodies and Alzheimer's disease as well into most of the figures. Just Parkinson's is where I work and where our work has developed, but we've done this very much in conversations with individuals across other neurodegenerative diseases, and I'm going to talk a little bit about why that is so important at the end. So this is where we live, right? This is what I'm going to be doing in clinic for the rest of the day today, is treating people who are in this box, who are having fluctuations, who are having motor symptoms, non-motor symptoms, etc. We've gotten a little bit better at catching patients at the very first presentation of their clinical syndrome, when they first have unilateral tremor or they start to have gait abnormalities. But these patients are actually still very, very hard to find when they first develop the symptoms. We've created a lot of these models for this prodromal space, and we've got a gazillion names for it, depending on which subspecialty you're walking out of. These are individuals who just have sleep disruption, or maybe they even have the full clinical syndrome of REM sleep behavior disorder. Maybe they have some mild autonomic dysfunction, or maybe they actually have a full clinical syndrome of pure autonomic failure. Maybe they just have hyposmia. Maybe they just have other things. But we've built these syndromatic precursor or prodromal definitions around this space, but they're very, very messy. And a lot of these things happen in the normal aging population, such as loss of smell, and then constipation being a really big one that is clearly a prodromal syndrome of Lewy body diseases, but also happens as part of normal aging. So how do we distill out people in this stage? We've used the word throughout this entire process of this integrated staging and this integrating biological definition. And the idea behind that is to have a biological definition that is able to encompass the entire red box. So not just individuals once they develop the symptoms, but individuals all the way from the time before they develop symptoms through those initial non-specific symptoms through the entire syndromic phase, which we currently work in. So the integrated staging strategy or integrated staging system that we talk about is integrated in that it goes across all of these. And as I said, we're not the only ones who are doing this. And in fact, we are the third. The Huntington's disease group were the first ones who really put together these models, this preclinical phase, and they actually put together a biological definition and integrated staging strategy several years ago. The folks in the Alzheimer's space have been talking about biological markers and a biological definition now for over a decade, and have now put together a more formalized integrated staging strategy. And then, of course, in the Parkinson's disease, dementia with Lewy body space, we're working on this as well. And what we're talking about is a shift from the right side of the screen to the left side of the screen, because we, again, clinically, we are all working on the right side of the screen. Very little is happening on the left side. Very little is happening in that preclinical space from a therapeutic development. There's a good bit of biomarker work, but we're not doing any therapeutics on that side of things for the most part yet. And so we're talking about this paradigm shift. In order to get to the left side of the screen, we have to move from defining our neurodegenerative diseases based on the clinical syndromes to defining our neurodegenerative disease based on biomarker profiles alone. Because if you're in syndrome-free individuals, you can't rely on the symptoms. You have to have something objective and something that's a biomarker. And this is why a biological definition is necessary. So what are some key principles behind this? So neurodegenerative diseases of aging are defined by their biology, and the biology right now we have is the pathology at final path. I think that's a first step. There's a lot of other biologies going on. These pathophysiologic changes precede by decades clinical symptoms and functional decline. I think most people agree to that. Biomarkers now exist that are sensitive to some of those pathophysiologic changes. And that's the key thing, is really identifying those biomarkers that truly have an exceptionally high sensitivity and specificity for the biological change. And therefore, if the detection of the pathophysiologic change by biomarkers is equivalent to diagnosing the disease. And I will just say that this last sentence is one that a lot of people are having a lot of struggles with, because those of us who are clinicians are very used to calling someone disease based on their symptomatology, and saying that someone has a disease who doesn't have symptoms is a little uncomfortable. And this is something that I think a lot of us have spent a lot of time thinking about, the unintended consequences of that. And I think this is an important one to think about. But if the things on the left are true, then as a consequence, it is actually necessary to separate the clinically defined impairment from the biology. And symptoms are a result of the disease process and not necessary to diagnose. And therefore, unimpaired individuals with abnormal biomarker test results at risk for symptoms due to the disease, they are not at risk for the disease they already have. Again, this is a paradigm shift in our thinking in the context of neurodegenerative diseases. So let's talk about some data in getting here. So the pathologic diagnosis is currently our gold standard, and I will just make a very strong statement. It is still our gold standard. It's very, very important to have these neuropathologic correlative studies so that we can truly understand how these biomarkers are telling us about what is going on pathologically. And so, again, I will be talking primarily about individuals who have this alpha-synuclein positive neuronal inclusions. This is images from the original 1997 paper that first identified alpha-synuclein as being the predominant protein that made up Lewy bodies, which, by the way, was also my very first journal club I ever did as a medical student, just by happenstance. And so, great paper, really, really ground-shifting paper. There are also other diseases of alpha-synuclein, and those are people who have predominantly glial inclusions, and that is under the clinical term of multiple system atrophy. There are some biomarkers that can separate these two types of alpha-synuclein inclusions, and there are some biomarkers that cannot. And this is a really important area that is currently under development. And so when I refer to predominantly neuronal alpha-synuclein, I'm talking about that middle panel, people who have those Lewy bodies on final pathology, versus the predominantly glial, which are the people who have the glial cytoplasmic inclusions at autopsy. Okay, so the problem is, of course, as great as I think my clinical diagnosis is, CPC after CPC and these wonderful neuropathologic papers continue to tell us that, particularly at initial diagnosis, we don't do the best job. We are somewhere for neurodegenerative diseases, 70 to 80% concordant with final pathology. As diseases progress, we get much better. We get into the 80 to 90% concordance, but we are not perfect, and that our clinical syndromes really do miss patients, and they don't account for what's really important, which we'll get to at the end, and that is co-pathologies. Our clinical syndromes really do not help us identify people who have co-pathologies, and it turns out co-pathology is the rule, not the exception. The other big challenge is that this is kind of the Venn diagram of Lewy body diseases, that depending on which comes first, motor, neuropsychiatric, cognitive, sleep, autonomic, sensory, we've got a different term for you. So each of these terms are referring to people who at final pathology have Lewy body diseases. And it just depends on what comes first, whether you're called Parkinson's disease, whether you have dementia with Lewy bodies, Lewy body disease, Lewy body dementia, PD dementia, prodromal PD, prodromal DLB, isolated RBD, and primary autonomic failure. If anyone diagnosed with these diseases was hit by a car and went to neuropath, they'd have Lewy body diseases in their brain. It is probably not the only pathology. There are probably other biologies that are pushing patients into one of these different clinical syndromes first, and I think that's a really important thing to distinguish. But there is a unifying biology underneath all of these, and that is the predominantly neuronal Lewy bodies that are alpha-synuclein positive. So there have been a couple of groups, I've been part of one of them, that have started moving this forward into thinking about a biological criteria for synucleinopathies. I just want to stress that these are very specifically at this point in time considered for research. So please don't go to clinic tomorrow and start talking about, rating people on the synergy scale or whether or not they're NSD or not. We're not there yet. These are research intended for now, but the idea is research intended for clinical trials. And if they are actually useful, particularly in the earlier stages, these will be translated into clinical use, but only if they help us to move clinical trials forward, and only if they actually are useful for being able to get positive clinical trials. And this is just a little bit of the timeline that we had with our working group, which started it's crazy that we just started 2 years ago in actually October of 2022 as we moved this forward fairly rapidly, and we're still working on it. Okay, so what is the biological definition? So we decided that really grounding in the synuclein pathology, since this is the hallmark that is found at Final Path, was absolutely critical. And again, the key being that biomarkers of synuclein pathology in living people, we believe, is now in its prime time, that we have very good validated evidence that these biomarkers are very good. So what are the biomarkers I'm talking about? There's two primary ones. Biomarker number one is referred to as the Seed Amplification Assay. It's also referred to as RT-QuIC or PMCA. You guys probably know this in terms of CJD. It's a modified version of that RT-QuIC. It's not exactly the same way. So basically, it has to be done in cerebral spinal fluid right now. People are trying it in other mediums, but it is not validated outside of CSF. So right now, it's only CSF. They take these recombinant alpha-synuclein seeds with a thioflavin T fluorescence. They put it in the CSF. They put it in wells. They do a process of shaking, fragmentation, elongation. If that CSF has alpha-synuclein that is predisposed to aggregation, it will form these fibrils. You put it into a fluorescence reader, you have an amplification, which is a positive SAA, or you have a not detected, which is a not detected or negative SAA. So it's a dichotomous outcome that you get from this. So this seed amplification has been shown now in a multitude of different studies to be highly sensitive and specific for individuals with a clinical diagnosis of Parkinson's disease. It's now being shown in dementia with Lewy bodies. And I wanted to show in this particular figure at the top here that there are two manuscripts now that do show that you can differentiate the MSA-like from the Lewy body-like, that people who have predominantly glial alpha-synuclein, it is this lower, the blue line here, it's an earlier amplification, but the total fluorescence is at a lower level. And that at this point, it's pretty high confidence that this can differentiate between the two. And I do believe that either now or very soon, the readouts are giving this type 1 and type 2 being the MSA predominant versus the Lewy body predominant. I will say there's less validation in the MSA, like there's only 2 publications that show that, whereas there's now over 20 publications that show very clearly that the Lewy body like is quite accurate. This is just a handful of the publications, and I think this is now 2 years old. So there's a bunch more that have come out. Okay, so for now, so this is a key issue, is that when we start thinking about these biologic definitions, again, we're focusing on synuclein biomarkers, but it's not necessarily hinged to this specific. This just happens to be the one that's validated for now. If this gets replaced by SAA in blood and SAA in skin or something else, then this will be replaced. The concept of a synuclein biomarker is a conceptual hinge. It's not necessarily saying, just this one biomarker. For instance, there's another biomarker that's emerging that's actually quite good as well. And that is this peripheral synuclein detection of immunofluorescence. This was originally published many years ago. This is done using a skin biopsy. It's actually 3 biopsies, one in the neck, one in the abdomen, one in the legs, has the highest sensitivity. And they basically they do a double labeling where they look for the neuron. And then if you have the phosphorylated alpha-synuclein, which is shown in red here, which co-localizes within the neuron, then this is considered to be a positive. This is one of the excellent studies that came out showing very good sensitivity and specificity within people who had Parkinson's disease, but also MSA, dementia with Lewy bodies, and primary autonomic failure. This does not seem to be able to differentiate between predominantly glial and predominantly neuronal alpha-synuclein. There is one manuscript that shows there's a bit of a pattern distribution that's different in MSA versus PD patients, but I would not consider that valid enough to, on an individual participant basis, say that the pattern says it's MSA versus PD or DLB. There's also some evidence by our wonderful Dr. Miglis that there are maybe some inflammatory conditions that people seem to have a positive synuclein test. For instance, he had a cohort of COVID patients who were positive on their skin biopsy. And so exactly how this plays out in the periphery with certain inflammatory conditions is still, I think, really important for us to understand. But nonetheless, it looks like it is, if you have predominantly neuronal or glial synuclein disease, this seems pretty accurate. So these are the two at this time validated biomarkers. I will say, if you invite me back next year, I really hope I have more than these two to say. There's a major effort going on right now to try to not only get additional biomarkers in the periphery, but also to get quantitative. You'll notice both of these basically just give you a yes/no readout, which is great. We all want to know, yes or no, my patient does or does not have a synucleinopathy, right? Or in a research study, people do or do not. But it is limited in saying anything about their disease severity, or if they are in that asymptomatic phase, how long they have to building clinical symptoms. A dichotomous outcome doesn't give us any of that information. So getting this into a peripheral medium and getting a clinically meaningful quantification are really the two, I think, highest priorities for research being done. And I am happy to say that there are several labs here at Stanford that are working on that I've been giving CSF and blood samples to. So maybe we'll be inviting some of those speakers to give grand rounds next year with their wonderful discovery of a quantitative or peripheral synuclein biomarker. Okay, so the other anchor within neuronal synuclein disease is neurodegeneration. And the reason why this is important is because we believe that the individuals who are synuclein positive but asymptomatic have not yet developed meaningful neurodegeneration. And so this concept of when someone develops the neurodegeneration is probably more functionally anchored, whereas the presence of the biology just tells us that they have a neurodegenerative disease brewing. So right now, of course, this is kind of the standard of looking at dopamine imaging. DAT SPECT is the most widely available. PET imaging of the dopamine system is also quite good. We've identified some blood and CSF markers for dopamine that are in the process of being looked at more extensively and validated. These aren't great to be used in people who are on dopamine replacement therapy because, unfortunately, when you're looking at markers of dopamine and someone's on dopamine, it really messes with the assay. But in individuals prior to starting dopamine replacement therapy, for instance, those in that secondary prevention who are synuclein positive, they actually might be perfect for these blood assays of dopamine. So a lot of opportunity there. So this biological definition, we termed neuronal synuclein disease, or NSD, which is defined by the presence of disease of predominantly neuronal alpha-synuclein and dopaminergic degeneration. And the biomarker context of use was simply to identify individuals in life who will have specific pathologic findings at autopsy independent of their clinical syndrome. So simply moving from the diagnosis being made by Tom Montine at autopsy to the diagnosis being able to be made at consensus conference based on biomarkers, which is a huge shift. And again, importantly, independent of their clinical syndrome. So identifying people who are biomarker positive. So who does this, this is anchored, of course, around synuclein positivity for now, or at the time of the first manuscript, based on the seed amplification assay, but any future measures could be used, including the skin biopsy or anything else that is developed. And then again, also measurable by DAT imaging, again today, by dopamine degeneration today by DAT imaging, but any future measures. So who would this include? This would include people who with a clinical diagnosis of Parkinson's disease who are synuclein positive, people with a clinical diagnosis of dementia with Lewy bodies who are synuclein positive, people with isolated RBD or PAF or other non-specific syndromes who are synuclein positive, and individuals with absolutely no clinical symptoms who are synuclein positive. It does not include individuals with those clinical syndromes who are not synuclein positive. So this is a huge, huge area of work, is to figure out who are these folks who have these clinical syndromes who do not have positive synuclein biomarkers. Is it a incorrect biomarker, or are we incorrect as clinicians? And I'm going to show you a little bit of data here from Stanford as well as from the PPMI that seems to implicate that the majority of the cases are that the biomarker is correct and that we as clinicians are not. So another important thing is that this is the idea of parallelism. We are in a very early phase of this process, and most people with clinical symptoms or even in clinical research will not have the biomarker data to determine whether or not they have neuronal synuclein disease. And continuing to use the clinical syndromes, PD, DLB, RBD in a contextually appropriate way is really critical. And so, for instance, if it's a syndrome-oriented definition, should currently be used in all clinical scenarios, in research when no or limited biomarkers are available, and then in research that's targeting clinical symptoms. If you're targeting, tremor, then maybe you don't need to know whether someone's synuclein positive or not. Whereas the biomarker definition should really be used in some research scenarios, but only when the appropriate biomarkers are available, and specifically as we start to move into these secondary prevention cohorts. So let me show you some data. So these are graphs that are commonly being used right now in looking at individuals across the spectrum. This was originally coming out of the PPMI study. So for those of you who aren't familiar with it, this is the landmark biomarker study that is funded by the Michael J. Fox Foundation. Originally, they recruited about 400 plus individuals with a new diagnosis of Parkinson's disease. So the diagnosis had to be within the last 1 to 2 years, not yet on any dopaminergic therapy. They had to be dopamine imaging positive by visual read, which was the standard at the time. That started in 2010. And then they followed them over time. And since the cohort has grown to over 1,200. Within these graphs on the y-axis is their dopamine imaging. So again, we use DAT imaging, and for this one, most of our studies, what we use is the lowest putamen ratio, and the horizontal line is where we draw the line between abnormal being above that, so you have normal dopamine imaging, and below that is abnormal. On the x-axis, we have smell, and the reason for that is that we have discovered through many of these studies that actually the loss of smell is highly linked to the synuclein positivity in these individuals. Now, we know at pathology that the olfactory bulb in people with Parkinson's disease and dementia with Lewy bodies is usually quite severely degenerated. Unfortunately, a lot of autopsies miss the olfactory bulb. It gets split when the brain gets removed. So a lot of autopsy studies don't include the analysis. But when you do ask neuropathologists, they'll all say, oh yeah, it's completely decimated. There's like no neurons left in the olfactory bulb. So we're not that surprised that that smell is associated. But if you look at this graph of individuals who had an abnormal DAT scan and an abnormal sense of smell, so that horizontal line at 18% here is kind of where we draw the line. 15 to 18% of expected for age on the smell test is what we consider hyposmic. So individuals, the closed circles mean that they had a positive synuclein test. The open circles mean they had a not detected synuclein. So these are people with a clinical diagnosis of Parkinson's disease, and almost all of them, except for those open circles, were considered synuclein positive. There are some caveats here, though. We have 3 different genetic cohorts within PPMI. The GBA mutation carriers, which account for about 5% of all Parkinson's patients. The LRRK2 mutation carriers, which account for 5 to maybe 8%, depending on the genetic background of individuals. And then SNCA, which is a pure synuclein, very, very rare, but a pure synuclein disease. Within individuals who are LRRK2 carriers, that's that middle panel here, you'll notice a lot more open circles. It's about 1/3 of those individuals have open circles. And what's fascinating is that about 1/3 of people with a LRRK2 mutation and a clinical diagnosis of Parkinson's disease at autopsy will have profound nigrostriatal neurodegeneration and absolutely no Lewy bodies and no synuclein staining on their path. And we have very limited data so far, but it does seem to be predictive that the individuals who do not have a synuclein positive biomarker in life are also the ones at final autopsy who do not have any Lewy bodies, but they do have nigrostriatal degeneration. And so there's probably a different process that is driving that. And there's a manuscript that is on bioRxiv, I believe it's under revision right now, that is looking at these synuclein positive versus synuclein negative LRRK2 carriers. And as you can see, almost all of them had normal smell. But there are some synuclein positive folks who had normal smell, which were LRRK2 carriers. So it's not a perfect correlation, but it is a pretty good biomarker. Okay, so then what about these people who don't quite have a syndrome yet? So what about the folks who have what we were previously calling prodromal? So individuals with just loss of smell or just REM sleep behavior disorder. So this is the two cohorts within PPMI. The one on the left is the hyposmic. So these people were recruited because they have loss of smell, but they have no other clinical symptoms. So this was our first round of community-based recruitment, where we basically sent out all these smell tests. People came back, they were below the 15th percentile. We asked them to come in and do a DAT scan and a lumbar puncture. Most of them said no, but some of them said yes. And so those are those folks on the left. So by definition, their upsit was below 15 percentile, because that's how we recruited them. And you will see a lot of these people have closed circles, have had a positive synuclein test. What's interesting is that a lot of them had a positive synuclein test, but their dopamine scan, of course, is above the horizontal line. So they had totally normal dopaminergic imaging. Same thing with these folks with REM sleep behavior disorder. So these are people who came in through PSG labs, like the one that we have here, found to have REM sleep behavior disorder. Some of them did have loss of smell, some of them had normal smell. And what's interesting is that if you had REM sleep behavior disorder and hyposmia, almost 100% of them were synuclein positive, even though their dopamine imaging was normal. The ones who had normal smell were not synuclein positive. And so the combination of RBD plus hyposmia was highly predictive of actually being synuclein positive, where some of these RBD patients who have normal smell, maybe the test isn't sensitive enough yet, or maybe they have a different biology and a different reason for their RBD. We don't know the answer to that question yet, but this definitely is hypothesis provoking. I do just want to comment that with these continuous measures, how you pick your cutoff matters a lot. Obviously, we've picked this 15 to 18th percentile on the upset, and we've picked the 65% for the lowest putamen ratio. But for those of you who are reading different manuscripts that are coming out in these cohorts, really pay attention to how they determine abnormal and normal. This is the problem with continuous measures and quantitative biomarkers, is that depending on how you do it, you might pick a very different cutoff. And so people might have very different concepts of what normal and abnormal is. This was a quantitative assessment of DAT, not a visual read of DAT. This was a specific quantitative assessment of DAT. And so really make sure you read the method sections before just kind of throwing out sensitivities and specificities. This is a really important thing. All right, so then this is not a study I was involved with. This was a very old study. This was kind of a precursor to PPMI that came out of the Penn group in the early 2000s, where they first tested this idea of using population-based smell tests. Here they sent out these upsits, and they anyone who had an abnormal smell, they asked to come in for a dopamine imaging. And within this group, they had about 200 individuals who had from the community in Pennsylvania, Philadelphia, who had loss of smell, about 100 who had normal smell. And of those individuals, only about 11% of them had an abnormal DAT scan. But this was pretty cool. Just by using smell, they could identify some people who had a biomarker of Parkinson's disease. And this was quite, again, these individuals came in, again, about 20 years ago. Well, a subset of them agreed to CSF at the time, and it's been sitting in a freezer for 20 years. And so they went ahead and sent this for the seed amplification assay. And it turns out 50% of them were synuclein positive. So a much, much higher number were synuclein positive than were DAT positive. Again, this is cross-sectional data, so it's hard to definitively say the timing of biomarkers, but here's two independent studies that show that hyposmic individuals who are synuclein positive might still have normal dopamine, again, implicating that there could be this temporal relationship between synuclein positivity and dopamine positivity. And they did have some longitudinal data on them. And the red lines here are the only folks from this group who did convert to a clinical diagnosis of Parkinson's disease. And it turns out only the synuclein positive individuals converted to a clinical diagnosis of Parkinson's disease, and none of the synuclein negative individuals converted within the 5-year follow-up of this study converted to a clinical diagnosis of Parkinson's disease or dementia with Lewy bodies. So showing an extremely high specificity of this biomarker for predicting conversion. Within the PPMI study, we've really expanded across the original cohort to identifying, again, broadly, I think over 50,000 smell tests were sent out across the country to have people come in over the age of 60, no clinical neurological diagnosis, who only have hyposmia. Originally, we were screening for DAT positivity, but then once we sort of figured out this temporal pattern of synuclein first, then dopamine, we actually loosened the dopamine threshold, and we're taking anyone independent of their dopamine. And so here is that plot, and this is under revision for this study. So again, community-based patients, no evidence of neurological disease other than hyposmia. They were brought in, and again, for this study, it was below the 15th percentile for smell. Closed circles were synuclein positive on their LP. Open circles are synuclein negative. So really showing that that these clinically normal or just hyposmic individuals can identify a large number of folks who show positive synuclein. Now, we don't know the temporal course between this and when they'll show clinical symptoms. As I showed in that first image, there could be a 20-year window. So that's why we're really, really cautious about this phase, that this is research only at this point in time, because these individuals might not develop any actual neurodegenerative disease for a decade or two. And we need to understand that temporal pattern. This, again, gives us a fabulous window of opportunity for intervening from a secondary prevention perspective, but we need to be very, very cautious about how we communicate this to individuals who have this positive biomarker, loss of smell, because we don't exactly know the temporal course for them to develop symptoms. This is the normal range for Parkinson's disease on DAT imaging, and as you can see, the majority of them had a normal DAT scan. So again, giving rise to this idea of a temporal pattern between the two. These folks will be followed longitudinally, and we will get both validation of the temporal pattern between synuclein and dopamine and more information on the conversion to a clinical syndrome. One of the best data sets that shows us this longitudinal prediction came out of the Swedish Biofinder cohort. This is 2 studies that recruited a couple thousand individuals from the community in Sweden. Biofinder one, I think one of them was the cognitively and neurologically unimpaired individuals, and then one cohort were individuals that came in with a clinical diagnosis of cognitive impairment. This study was tailored toward Alzheimer's disease, so quite frankly, it was lacking really good Lewy body, Parkinson's dementia with Lewy body markers, but they did have enough that they could retrospectively go back and test all of their CSF samples for synuclein and look at what happened. And so they had a little over 1,100 individuals neurologically normal. So they were not screening for loss of smell here. So these were truly neurologically normal. They did test smell and within the cohort, but it wasn't screened for smell. These were just their healthy control cohort, basically. So 1,100 of them in the community, 94 of them had a positive synuclein test over 10 years ago when it was tested. And if you look at the curve, this is a Kaplan-Meier of the risk of converting to a clinical diagnosis of Parkinson's disease or dementia with Lewy bodies. None of the synuclein positive older adults converted within 10 years to a clinical diagnosis, and an extremely positive Kaplan-Meier for the risk of converting. This is the best data we have on longitudinal prediction. So growing evidence, in my opinion, shows that these synuclein positive, neurologically normal older individuals are not false positives. So we keep seeing these cohorts get published with healthy controls and saying, oh, 5% were synuclein positive, false positives. I don't think that's true. I think these are biologically abnormal individuals who have not yet manifest their clinical symptoms. We need more studies to show this, to understand this, but this is, again, the window where we have the opportunity to intervene from the perspective of a secondary prevention. I'll just show a little bit more data and then wrap it up so we have some time for questions. In their cognitively unimpaired group, they also looked at the cognitive trajectories. And it turns out individuals who had multiple biomarkers, so Alzheimer's biomarkers and Lewy body biomarkers, that's the pink line, had the most aggressive cognitive decline over the 10 years. And interestingly, in the individuals who came in cognitively impaired, again, if you had a collection of biomarker positivity, amyloid tau and synuclein, you had the worst cognitive trajectory. Going to this idea that multiple biomarkers are actually far more important in these individuals than looking at a single biomarker alone. We found a similar thing in our cohort here. We looked across the Alzheimer's Disease Research Center and all the banked CSF that we had in our cognitively impaired and neurologically impaired individuals. We found about a 8% positivity rate in our healthy controls for synuclein, about a 10 to 15% in our mild cognitive impairment AD group, and about 10% in our dementia AD group. Actually, other studies have found a much higher synuclein positivity. The ADNI cohort was, I think, 35–40% synuclein positive in their Alzheimer's disease, amyloid positive Alzheimer's disease cohort. And what was interesting, because we had longitudinal follow-up, these were the cases where there was a mismatch, where either the initial clinical diagnosis was not a Lewy body disease, so it was either Alzheimer's disease or healthy control, but the biomarker was positive. And when we looked at longitudinal follow-up, all these individuals over time showed evidence of developing Lewy body disease, either with visual hallucinations, REM sleep behavior disorder. 2 of them went to final pathology, clearly showed that they had Lewy body disease. And then 2 of the individuals who had a clinical diagnosis of Parkinson's disease, one of them being mine, I just want to point that out, whose synuclein test was negative, later had the diagnosis was changed to multiple system atrophy, so was not a neuronal synuclein. So again, showing that this biomarker, as much as I love my clinical diagnosis, probably is doing better than we are clinically. And the other, I think, the most provocative data is coming from the PPMI cohort. This is data that's being looked at by our fellow, Dr. Jung-Hyun Ha, along with Tom Montine and his team. So these are individuals who had LP at the time of diagnosis in the PPMI study and then have now gone to autopsy. The y-axis shows the time between when the lumbar puncture was done and their final autopsy. These are the folks who had a positive biomarker test and at final autopsy did in fact have Lewy body disease. These 2 individuals had a negative biomarker test. The one at the top was in the sporadic Parkinson's disease group, had a very classic Parkinson's disease presentation. Later on, that diagnosis was changed to multiple system atrophy. At year 7, they came to autopsy and it was confirmed that they had glial cytoplasmic inclusions at autopsy. And then this individual was a LRRK2 carrier who had, again, a negative biomarker test, and at autopsy was confirmed to have nigrostriatal degeneration, but absolutely no synuclein staining on their final autopsy. So again, showing 100% concordance between the biomarker and the final autopsy. We've put all of this into a staging system so that we have these different levels where we have individuals who have this fully penetrant deterministic gene. These are super, super rare folks in the context of Parkinson's. These are only the SNCA. We have these folks in stage 1, these asymptomatic biomarker positive individuals, people that could be enrolled in these secondary prevention studies. Stage 2, this minimal clinical symptoms, hyposmia, sleep disruption, those kinds of things. And then stage 3, which is where we, again, clinically currently live, where there's functional impairment. But I just want to say that this is a framework, and this is our first iteration. And I really, really expect this to change at a fairly high frequency as the data tells us. I think it's a first step, but it is very much a first step. And again, I think that there's a lot to learn. And the key thing is that iterations will happen as our data, our knowledge, and as our technology evolve. And the biomarkers I'm most excited about are actually the ones that aren't synuclein or dopamine, are the ones that are in the immune function, mitochondrial function, lysosomal, synaptic density. These are the ones that might tell us why somebody goes to a cognitive first versus a motor first, or something that's happening prior to the development of Lewy bodies. So this is really critical. I think that overall, This framework is really important as we consider participants who have a unifying biology, which will increase our opportunities for successful trials. I think it's critical we consider this mixed pathology that the BioFinder study showed, as well as others, because I think that there's opportunities for multiple interventions and combined therapies, as well as, again, population-based targeting of earlier individuals in a syndrome-free environment. So just to sort of bring it together, the idea here is that biologically defined diseases, and here I'm switching to the Alzheimer's disease model, we think that there's a causality between some sort of genetic and environmental factors interplaying. We think that there's some cascade of pathophysiology that we don't fully understand that includes different things, lysosomal, mitochondrial, immune, which leads to the pathology of, in the case of Alzheimer's disease, amyloid and tau, and neurodegeneration. And we call this a clinical syndrome. But we know that there's co-pathologies that are involved here as well, vascular, synuclein, and others. And so there's multiple clinical syndromes. We also know within the context of neuronal synuclein disease, a very similar cascade occurs between the causality, the pathophysiology. It's just a different pathology that develops, and we call these a different clinical syndrome, Parkinson's, dementia with Lewy bodies. But again, there's all these co-pathologies that are involved. So the idea is for us to move beyond this single syndromic and actually start moving toward a multiple neurodegenerative biological definition, where we look across these clinical syndromes and really have a much more comprehensive biomarker characterization that is independent of the clinical syndromes as we start to move toward this. And this is critical because if we're going to move toward that stage where people have no or minimal clinical syndromes, we can no longer define these things based on whether they show up in the autonomic clinic or the behavioral neurology clinic or the movement disorders clinic, because they won't have those symptoms yet. So we have a long way to go before we get here, so that we can have agnostic of the underlying pathology, disease-targeted screening, and disease-specific targeted interventions. I think there are a lot of steps that need to be done before we get here. This is a bit of a roadmap that that my colleagues and I have put together. That these are the highest, really the highest priority data that we need to move forward. We clearly need the longitudinal data. Biomarkers are in a very complex landscape to understanding a lot of the interactions between these biomarkers. We clearly need to understand how they evolve within the context of other things that we cannot measure yet, such as TDP-43 and even other pathologies, to work toward a comprehensive biomarker panel. We obviously need a quantitative and more reliable biomarkers in the periphery. We need to do validation in more diverse cohorts. I will just blankly say that every single piece of data I showed you today are predominantly in non-Hispanic, white, highly educated individuals that come from the US and Europe. And we know for a fact that there are genetic differences between individuals from different backgrounds in their risk of neurodegenerative diseases, and we quite frankly know nothing about the biomarker differences, particularly as we're thinking about peripheral or skin-based biomarkers. So this is a huge area that needs developed. We also need to understand what are the biologies underlying these people with a clinical diagnosis that looks exactly like Parkinson's disease or exactly like Alzheimer's disease, who are biomarker negative. Is it our biomarker or is it something else? And right now we're doing a deep dive into these open circle individuals. I've sort of been obsessed with them over the last year, and we finally have enough to actually look at them. And finally, we have to have minimally invasive, cost-effective biomarkers if this is ever going to move to a true screening paradigm. And it's also necessary if we're going to have a more inclusive cohort of individuals that we're looking at biomarkers. But this has a potential unanticipated side effect of also potentially, if something's cheap and easy to do and minimally invasive, that biomarkers could be used inappropriately in a broad way. So a lot of education needs to happen with this regard. So I'll end with the slide that I started with, and saying that, you know, I think that we have a long way to go. I do believe the first steps and the roadmap towards secondary prevention has begun. And the key here is understanding these neurodegenerative diseases in a biological way versus a syndromic way, which is a huge paradigm shift for us in neurodegenerative diseases. And I think one that is going to be a continuous journey. I hope it is a data-driven and a factually grounded journey forward. And I look forward to sharing with all of you the wonderful developments that are going to happen over the next few years. Thank you very much for your attention. I'm happy to take questions.